Good afternoon to all. Welcome to Toronto Institute of Palliative Science and welcome to pallicovid echo sessions 5. And today we have sessions on ethical issues, goals of care and triage in context of COVID-19. And this sessions will carried by Dr. MHOIRA, and I hand over to Sunil sir to facilitate this session.
Thank you, Arun. So good afternoon, everybody. So we have another important session today. So we have seen that many patients will have breathlessness and many other problems. And we don't know which all patients will be benefited by which all interventions. So Dr. MHOIRA will be speaking about on that. And she is a specialist palliative care physician, currently acting in 2 roles: head of palliative care at MHOIRA University, Uganda, and also the medical director of CADIS International, Scotland. And she has traveled extensively and was helping many palliative care physicians to be as a mentor, working with many institutions for curriculum development and many other things. So she has worked and has been a mentor for many of us in India. She has many years of experience in palliative care. So welcome, Dr. MHOIRA, and it's over to you.
Thank you, Sunil. Thank you for those kind words of introduction, and greetings to everyone on this call. It's lovely to be doing these webinars regularly and to have different groups. You'll have different experiences. We'd really like to in the discussion, we'll have plenty of time for discussion to get your experiences and your points of view. But let me see if I can just get this screen shared. Okay, so this is one of the tricky issues that we're facing in this current pandemic, although some of the principles are there in any situation where we've got to make difficult decisions. So we're going to look at this thing called triage, so that's the process of making clinical decisions. And we're going to look at the ethical issues and frameworks and give you some tips and tools moving forward. You already had my introduction, so you can see there we have a website if you want any information about what I do. But I also want to emphasize, most of you know this, but please download the ebook. It's being updated very soon to another version. The algorithms will just be tidied up in due course, and we're relying on feedback for that, so there'll be an opportunity for feedback at the end. We're also not teaching the general palliative care and chronic disease issues, although they come up. So if you want to know more, particularly about adult symptom control, have a look at this app, which is an excellent summary of symptom control for adults, developed in Bangalore. Okay, so let us discuss background for ethical decision making, how to balance ethical decisions in the clinical scenario, triage and goals of care, and lastly, looking at our values. So as I start to look at ethics, I'd like you to see if you can quickly scribble down the 4 major principles by which we look at ethics. Now, while you're doing that, we'll see it on another slide. Let's see how well you do. I think you're going to do pretty well. These guide health professionals. They're only principles. They're not rules, they're principles. They allow us a framework to start thinking. We need to apply that in our cultural context. We need to think about the legal frameworks we work. Ideally, they are based on good ethics, but they may or may not be. And we also know that these kinds of decision makings become even more important when people are approaching the end of life, and when emotions are running high, and perhaps there isn't time to do so many discussions, particularly in the light of a pandemic. So we need to apply these principles to that person and family. They're individuals that we are making decisions with. I think that's important. We're not making blanket decisions based on age or economic status, even worse. And we're wanting to look at the wishes and best needs of that person and their family, and of course taking into account the wider society and resource allocation, and that's what makes it very challenging. In fact, it can feel like it's a tightrope, that it's impossible. I want to take us through just step by step how we might think through that tightrope and therefore be able to reach a better outcome for ourselves and for our patients and families. Now, did you remember all four? If you did, give yourself a little pat on the back. Patient autonomy. This is the need and the principle that a person must make their own decisions. But to do that, they have to have open and honest communication. We must not get caught in that trap of families asking us not to tell patients, though of course it's okay for patients not to know if they don't know. We'll talk about that later. And in our societies, often families are involved collectively. Beneficence and non-maleficence. Is this harming? Is this helping? And that means both treatments we give, but also decisions not to give treatment. It may be that doing a particular treatment is of no benefit and therefore is of harm, particularly if it has side effects, if it separates people from their families, if it removes choice of things like the place of care. So we have to balance those things together. And of course, this last one, which is tricky, and I'll talk a bit more about, the fair utilization of resources. Collective decision-making is not something unfamiliar to most of us. There's a concept which I love in South Africa called Ubuntu, which talks about I am because of who we all are. Desmond Tutu, famous for his work in the Truth and Reconciliation Commission in South Africa, famously said this: my humanity is caught up, is inextricably bound up in what is yours. And I was privileged to visit Manipur recently and see something of this principle of Kanko working in the Kuki peoples, which again is that sense that what I do has an impact on you and vice versa. So we actually live in a more symbiotic relationship. And this will be familiar. I've been reflecting in the time of COVID-19 how important this is, because our actions are having a direct consequence on somebody else. And other people's actions for us as healthcare workers can have quite a serious impact on ourselves. So it's reminding us that we actually have to live in this sense of community and mutual appreciation and mutual support. Now, this is the tricky one. We live in the reality of constrained resources individually and also in our institutions and national settings. I would, however, say that if you're working in a low and middle income setting, you've been doing this every day of your healthcare practice, trying to balance what you have with what the person needs. And I think many of you have been advocates for improving that situation. In palliative care, we have been fighting for the right of a person to be free from pain, for example. Many of you are working in your own settings to get the best possible quality of care and to push for universal health coverage. These are all issues which would address some of these justice. If there was universal health coverage, then that by definition should not mean a financial load for people with chronic disease. But in the reality of today, and in the reality of the COVID pandemic, we need to take this into account. But I suggest you take into account this issue along with the individual. So don't just say everyone over the age of 60 will not get X. Everyone with this will not get Y. What do you do when you see what's the available resources? What does this person going to benefit from? And how is that going to impact on how I can care for the next person and the next person? And do remember, back to this non-maleficence, we can do harm with our interventions. So if an intervention such as invasive or non-invasive ventilation is not likely to have benefit and may well have harm, we are not ethically obliged to do that. That's a principle of futility. It is a balancing decision and one you should make in consensus and in discussion with the patient and family. I want to take you through this journey of this palliative care, emergency doctor from the US, talking about her experience of the pandemic and saying, all doctors are palliative care doctors now. And I think you could change that to all healthcare workers. And she was just reflecting that suddenly she's finding herself in a situation where she's offering solace, reassurance, and relief. She's preserving dignity. She's looking at the distress. There's an excellent webinar on distress in the series. Please look at it. And she's talking about existential uncertainty. That's the spiritual dimension of care. She's also looking at the patient's values and priorities, and that's an essential part of ethical decision making. And of course, she's assuming one size doesn't fit all. Again, that's the idea that we must treat the person as an individual within their society and community and within the ethical framework. But she's also talking about bearing witness and easing suffering and reminding us that that is the heart of medicine, that there is always something more to be done. And we're privileged for those of us who are working in palliative care. And if you are not and you're here to gain skills, you're very welcome, because this is a really important thing we can do. We can just move a little away from feeling we have to cure everyone to saying, I have to bear witness to and ease the suffering of all. And that may improve length of life, but it should also improve the quality of life. And that's a transition people have to make in their healthcare careers at some point or another. And when you do it, how rich it is to know that actually the value of what you offer as a person, the way in which you offer it, as well as your clinical skills, can make a big difference, particularly in patients feeling valued and seen. And I'm going to say a little bit about this later. I've mentioned the legal frameworks. If you're working in an Indian context, here's some excellent papers that will help you think that through. They were jointly done with the Critical Care Society. And in fact, the most recent one is looking at COVID-19 triage. So that's more for the triage around intensive care. So if that's what you would like to know, please click on this paper and find out more. There has also been changes in the Indian context at the Supreme Court, and that legislation is still working it through. There is some guidelines that are based on institutions. You see two there, Manipal Hospital and AIMS. And there's also a very recent paper, which is literally just coming out, looking at do not resuscitate orders in the light of the current Supreme Court legislation from Dr. Rup Goswami. So quite a bit to help us, but we still can feel it's like a maze. We still can think, okay, I know where I need to get to, but how do I get there? How do I handle the high emotions? How do I do the best for my patients and my families? And I like that these papers that I just mentioned include some very lovely philosophical thinking. You know, we don't leave poetry behind when we come into medicine. We take it with us to help us understand the humanity. And living with the reality of life and death is important. And seeing death not always as a failure. It may be part of life's journey. Death is not extinguishing the light. It is putting out the lamp because the dawn has come. And we may have a role in accompanying people on that last journey with dignity and compassion. So this current pandemic is causing us all sorts of challenges. You know, there's the social isolation, the vulnerability, the desperation and worry that people are having, very unequal access to resources. I'm speaking to you today from Uganda, and that's so obvious. And across India, particularly in the north, we're seeing such problems with these moves of migrant workers and so on. Real inequality. The holistic issues, particularly mental health and other issues, are often ignored. There is huge stigma. You know, we've heard the stories, doctors who can't even be buried after they've died of COVID because of the stigma and fear, people being beaten, people being chased away, even worse than that. And we hear words like victim and suspect. I've even heard kids here run after people who they think might be high risk and shout, "Corona, Corona." These are all part of stigma. They come from places of fear, and we need to work with our communities to deal with these and not take them for granted. They must be dealt with. And of course, they're particularly important in making sure that we as healthcare staff are safe in our places of work. So when you start to think of ethics, you need to have it within a context and a plan. This is the WHO plan for COVID-19. It's excellent, and it takes you through step by step. But you need a communication system for healthcare workers, and as I've just mentioned, the community need to be engaged for the general population. You need to have a system of testing, and of course nearly every country is struggling to get this right, but we need to have a system of information and testing, and then on to treatment decision making. We need to do that at the appropriate level. In this webinar, we're talking more about the non-ICU decision making, but it has commonalities in all settings. And of course, holistic issues and staff support. You can only look after the next patient if you yourself are restored and refreshed. I'm sorry this doesn't show up so well. You'll find the updated version of this in the ebook, but it's an attempt to show you how Kerala has done this, how our ebook and our algorithms come in at different levels of the health system to support the government structures that are in turn rolling out palliative care. I want to mention just one issue about communication. There's an excellent webinar on communication. Again, I encourage you to look at that and to join that. But when we get into goals of care discussion, which we're just coming on to, I think having some frameworks in mind, if this is not a familiar area for you, are helpful. And here's one, Spike's tool, quite a long-standing tool. It talks about the importance of setting up the interview. Now, if we're in a pandemic setting, this may not be straightforward with masks and PPE and so on, but you can still adjust your body language. You can still do something with your eye contact. You can still have a badge or something else, and you can lean in and give that impression while still staying safe that for this moment, this person is important. Their views are important, and what's happening to them is important. We need to try and find out what the person knows and what they would like to know, whether they would like a proxy or a family member to be in on the conversation, or even have the conversation with them instead. And when we've done those stages, we get to what actually doctors sometimes get to very fast, giving knowledge and information. That comes after this bit of checking and setting of the environment. Avoid jargon, give straightforward and use your skills of empathy, use your skills of letting people reflect, use silence, use presence, and then summarize. And that's the point. Maybe we'll be making decisions or attempting to make decisions. It may be a process. And can I just remind us of the value of presence, of just being? This picture is quite moving, and it shows, someone it was a COVID-19 setting diagram, but they're in hospital clearly, but there's somebody bearing witness. Can you see that? I have just been chatting with my sister who came out of hospital yesterday. She was telling me as she came back from theatre, a nurse sang with her. And she's remembering that, and she's remembering a very kind gesture that was given, even more than the clinical skills. So don't forget your acts of kindness, ways in which you can show compassion and preserve dignity. This heartfelt cry from Zimbabwe, this young journalist saying, I'm alone and scared in ICU without intensive care input, but alone, and sadly died like that. Let us make sure people are not dying that way, if indeed they have to die because of COVID-19. So here we go to our goals of care discussion framework. Again, on the screen, you might find this difficult. I'll talk you through the principles, but you'll be able to download it from your ebook. It starts at the top by saying there's some people we know are going to do better than others in a general sense. Remember, we apply the general to the particular. So if we know that people are relatively young with no comorbidities, they continue on into the normal COVID treatment management in your setting. But we're wanting to think particularly about those who have comorbidities, who may be older, who are quite severely affected, maybe hypoxemic, and particularly those who are deteriorating. So in all of those circumstances, particularly these high-risk individuals, we need to use our communication skills excellently and find out what preferences are. Try, if you at all possible, if any of you are in chronic disease settings, please have these conversations early. Please let it be that you come into hospital having had these, what I call anticipatory care discussions, so that this is a checking procedure, not thinking about it for the first time. We go through whether the patient wants to know. We then start sharing information, which of course could be very reassuring. Young patients with mild symptoms are going to do very well from all the evidence, but we tailor it to the person we're speaking to. And that includes, if appropriate, discussions about withholding or not starting or withdrawing treatments, and also end-of-life care. This goals of care algorithm has lots of tools at the end to help you. I mentioned one, the spikes tool, some of the other ones we brought up in other sessions, but use all your empathy. This must be a very distressing time for you all. If we can just take it step by step and see if we can find a way through together. Don't make the mistake of the families thinking that there's a competition. Otherwise, they're going to then fight you every step of the way. Say to them, you know, I want to hear what you have to say. I want to know what your patient feels, and I want us together to do the very best for your patient. And then on to the management of ethical issues. And again, there'll quite soon be an updated version of this on the ebook. But this is just what we said already in the goals of care. If you have straightforward scenario, you go down the management structure. But if you are in this comorbid group, then we have to think, could you still benefit from non-invasive or invasive ventilatory support? A lot more evidence looking at non-invasive these days. If so, of course, onto ICU. We know that even in the highest income settings, the mortality rate is very high in ICU, perhaps as much as 70% in some settings. At every stage, good psychosocial and spiritual support. And then we take down this left-hand side patients who are unlikely to benefit from invasive support. So then we need to come to a clinical consensus, and don't do that by yourself. Ideally, we check that out with a triage supervisor, someone who's in charge of the floor, but not directly interacting with that person. We communicate to the family, having documented very carefully our clinical decision. And ideally, we then come again to a consensus with the family, calling for backup if we need it, and if absolutely necessary, bringing in ethics committees. We should ideally pass some of these things by our ethics committees and work in the ethical frameworks of that institution. At all stages, remember your excellent holistic and symptom control. And also, if the symptoms are severe, deteriorating rapidly, or refractory, be prompt and quick to get good symptom control started. And you have all those algorithms available in your ebook. The guidelines at the end of this algorithm, I think we already said: communication, documentation, recognizing futility, and communicating that well. We've also mentioned the importance of managing refractory symptoms and end-of-life care. Now, when we're making that assessment, I mentioned comorbidities. I mentioned that age is a factor. It's not a cutoff, but a factor. If somebody has a very short life expectancy because of another underlying illness, that's also a factor. But we chose to use this tool to help us assess the functionality. There are other tools, I'll show you them in a moment, but this one's quite familiar, and as you can see, it just takes through how much is someone able to do for themselves. This is a pre-COVID functionality and is the kind of what is the normal state of affairs for this person. And we're only looking at 3 and 4, and probably mostly 4, as people who are not going to benefit from further interventions. Excuse me. There are organ failure scales that people often use when they're in ICU settings, and such as this SOFA scale, that they talk about outcome. And we have the clinical frailty scale, which is used in the UK, for example, to help us make similar decisions. Have a look at these and decide what's best in your setting. This is not the first pandemic we've had, although it has particular characteristics. And these principles were developed for the H1N1 flu pandemic and then adjusted from the Royal College of Physicians in the UK, in Edinburgh. And I like it. It talks about accountability. That's about that communication and documentation, inclusivity, being clearly transparent. That's important in case there's any come back to you as healthcare professionals. To be reasonable, you base it on the best ethics and values and the setting you're in, and you be flexible. If a new treatment comes about, if something changes, we're flexible in the way we do this. We're not stuck in one way of doing things. And the global palliative care organizations have been producing some excellent briefing papers. I highly recommend them. And this is the one on ethics. And I like the fact the very first one is non-abandonment. You know, that's one of the desperately difficult things about COVID-19 is that sense of being isolated and being alone, being abandoned. So let us make sure, however we do it, whether it's using our technologies, whether it's the being, whether it's the presence, that we address this issue of abandonment. And I also like that reciprocity is there, because we, of course, as healthcare workers need to be just as much caring for each other and for the public health as for the person in front of us. And that's why we're keen to promote and demand, if need be, safe working environments. So we've talked about needing to preserve the continuum of care. If you're working, for example, in family practice, this is such an important role you have to have these discussions early, those of you working in community care. Have the frameworks in place. Make sure you've got effective communication. If you need to brush up on your skills, do that. Use these webinars and other tools to do that. Document, communicate. Have some supervision and document that. Use those frameworks. Make sure holistic issues are there for you and for your patient and family. And those issues of discrimination, where we're somehow seeing some people as more worthy of treatment, even unconsciously this can happen. Please be very conscious of the dangers of discrimination and try and challenge that in your own self and in your setting. Let me take you on a little journey again with another two doctors that were conversing from Italy to New York and published that conversation. This Italian doctor, overwhelmed in the emergency room, didn't know how to cope and is saying, I almost can't be human, because if I am human, I can't cope with what's happening. Distancing, very common tool that we all use to cope in the short term. And the doctor in the US is saying, yes, I'm used to doing everything. I'm used to almost kind of seeing myself as a medical savior, pushing mortality to the very edge. She can't do that. And how is she feeling? Helpless. And maybe some of you are feeling like that. And I mentioned before that transition from a curative approach to a caring and cure approach is painful and can lead us to feel helpless and useless. But then do you see what they're both doing? They're both coming to the point of saying, but actually it's being human with patients and families. It's painful, but it's in doing that that we can make a difference and that we can keep working, that we can find some meaning and some way forward in this setting. And what they're talking about is the key parts of palliative care, that it has to be something about that common humanity. The term common humanity, humanity to infinity, was actually used by a medical student in Gaza when I was asking him about his experience of the palliative care teaching as an undergraduate. Now, remember, Gaza has been in lockdown for 11 years. So when he said humanity infinity, it was a sort of clever superhero call, but underneath that, what immense meaning and richness there is in that. What does it mean, humanity infinity in COVID-19? And remember those moments. And many of you will know Irfan Khan, who's made a huge impact in his life, but actually has made a huge impact in his leaving of this life. And this is a powerful quote. I suppose in the end, the whole life becomes an act of letting go. But what always hurts the most is taking a moment to say goodbye. And sometimes by having these conversations, well, we're allowing those moments of saying goodbye to happen. We may be physically distanced, but we're promoting social togetherness and global solidarity. This is something that's affecting everyone. Thank you for being part of this webinar, and let us stand together to make a difference. We've given you a lot of resources and references, some of which will be relevant for your regional areas if you're not joining from India. And we've also given you some documents that are international that you can see. Thank you to all who contributed to this excellent webinar series. And we're also asking not just for the echo feedback, but for specific feedback so that we can understand more of how these webinars are being used and how we can improve our ebook in particular. Thank you very much. And I'm looking forward to now some good discussion.
Thank you, MHOIRA. So the session is open for discussion. Yeah, Sister Nimi.
Hello.
Yes.
Thank you very much, Doctor. I'm happy that you spoke about these issues. And I would like to clarify with you, if I am not mistaken, I know that you are speaking from Uganda. And Uganda is one of the countries that is leading in palliative care. I think it is more than us Indians. So what do you think we are lacking, or what do you think we need to improve as a country to improve the palliative care?
MHOIRA,
Thank you, Sister Nimi.
and Sister Nirmala has been working in Uganda, and I think she has been there for many years.
Working in where?
She was
Yeah,
working.
I had been in Uganda for last 11 years. I was working in one of the health center in Barara and Luwero. So I know that you are also there in Makerere University.
Hey.
And there, you know, in northern Uganda, you see the life is not easy, especially Gulu, Aru, those areas. But now,
Sister Nirmala.